Hi everyone, my name is Shuo Huang. I'm a researcher at the University of Maryland Department of Health Policy and Management, and today I'm here to talk about our systematic review of cost-effectiveness analysis of MRgFUS versus deep brain stimulation. So in summary, there's significant overlap in current methods in the literature and over-reliance on modeling. There's a dearth of studies and a lot more are needed. MRgFUS likely costs less than deep brain stimulation. And for essential tremor, MRgFUS is likely cost-effective or cost savings. For Parkinson's disease, the evidence is less substantial. So both essential tremor and Parkinson's disease are extremely disabling movement disorders affecting around 1% of the population. They're sometimes conflated with each other. Deep brain stimulation is indicated in medication refractory essential tremor, but it's a major surgery and there are major complication risks. MRgFUS is a non-invasive procedure with less intense follow-up with similar therapeutic outcomes. So what does the literature say on the cost effectiveness of MRgFUS versus DBS? So to answer this question, we have to look at what are the important measures for cost effectiveness. One of these is total cost. Another is the effectiveness, and then we combine these two measures in something called the incremental cost effectiveness ratio. So one treatment might dominate the other, which means it costs less and has better outcomes. One treatment might cost more, but also have better outcomes. And in that case, there are kind of two scenarios. Either it comes in under our willingness to pay threshold, in which case we consider it cost effective, or the ratio comes in over our willingness to pay threshold. It's often been set at $50,000 per quality adjusted life years gained, but that's a controversial threshold and it's not necessarily universally accepted. So our methods, we use the Prisma 2020 to structure our systematic review. We searched for the following terms on PubMed and Google Scholar. We looked at essential tremor and Parkinson's, in addition to MRgFUS, in addition to cost effectiveness analysis, cost utility analysis, or ICER. And what we extracted were the country, the medical condition, analysis type, time horizon, analysis method, source for the cost data, source for the effect data, effect measure, cost effectiveness measure, and their actually used perspective. And we also extracted and harmonized currency denominated values for the cost of MRgFUS and DBS in 2021 US dollars using same year currency exchanges and year over year inflation. So we found 26 articles with those search criteria. 22 were unrelated. 2 of the remaining 4 articles were from the same collaboration with the same method, so we kept one of them, and we retained a total of 3. 2 of these articles analyzed essential tremor, 1 analyzed Parkinson's disease. All 3 were cost utility analyses. None of them collected patient data. None of them collected cost data. Instead, all of them drew from the literature to fill in model effects, rate of complications, and utility weights. All used decision tree analysis, with one of them additionally using Markov modeling. 2 of these were set in Canada and 1 in the United States. All 3 claimed that they were using the societal perspective, but based off of the literature that they were using, they were functionally all coming from a public payer's perspective. The time horizons varied from 3 years to 5 years, or no time horizon was reported. And this is important because different time horizons can have drastically different effects on calculated cost effectiveness. All 3, again, modeled their costs. The 2 Canadian studies relied on fee schedules and the literature, and the US study used the reimbursement for stereotactic radiosurgery as a stand-in for MRgFUS. So the total cost of MRgFUS was reported between $11,800 and $23,700. The capital costs were excluded in one study and left unreported in the other 2. The total cost of DBS was found to be more than the cost of MRgFUS in all 3, with a range from $18,800 to $51,900. So in terms of the incremental cost effectiveness analysis, One study for essential tremor found an ICER of 111,000 for deep brain stimulation versus MRgFUS. And depending on the willingness to pay threshold, this means that MRgFUS is likely more effective than cost-effective than DBS. The other study for essential tremor found that MRgFUS outright dominates DBS, and the study looking at Parkinson's disease found ICER of 45,000 for deep brain stimulation versus MRgFUS, which means that MRgFUS is likely less cost effectiveness, depending on again the willingness to pay threshold. So in conclusion, MRgFUS seems to cost less than DBS, at least across all three of these studies. For essential tremor, only 2 studies exist. MRgFUS is likely cost-effective compared to DBS using our commonly used willingness to pay thresholds, or it outright dominates DBS. And for Parkinson's disease, only 1 study exists. And in that study, the cost-effectiveness of MRgFUS versus DBS is likely less substantial. So there are many remaining gaps in the current literature. One is the lack of directly collected cost data and the over-reliance on fee schedules in setting or approximating the total cost. Modeling methods are especially sensitive to cost assumptions, and particularly around complications and follow-up visits and things like that. There's also a lack of directly collected patient data. Direct data would allow researchers to look at the effect of complications and follow-ups, not only on total costs, but also on the utility and effectiveness of each of these potential treatments. And there's also, because you're not using directly collected patient data, there's this high potential in these modeling studies where you're drawing the population for DBS, for example, from one population, but you may be drawing the population for MRgFUS from an entirely different population. And so if these underlying study populations are unmatched, there's a high chance for bias. The lack of studies examining from a provider's, a patient's, or a societal perspective also limits the ability, particularly of providers, to make decisions around whether or not to start an MRgFUS program. And this holds true also about assumptions for capital costs and time horizons. These need to be made explicit and are likely going to be made more explicit once you do directly collect cost data. And this is, again, especially important for providers who are trying to decide whether or not to enter the market at all. The methodology is very similar across all 3 existing studies. This raises risks of systemic bias, so different studies with varied methods are needed. And also just overall, the research outputs are sparse. There are only currently 3 studies and more are needed. The co-author on this is Dr. Luisa Franzini from the University of Maryland, and the Focused Ultrasound Foundation was very generous in providing funding for this review. And our thanks to Michael Broad and Thomas Andre from FUF for advice and engagement on the topic. Thank you. This is my contact information if you have any further questions. And here are our references. Thank you very much.